discuss as exam is near, and we should, I think, quickly revise the obstetrical emergency. So there are very, very important few, safety points uh, to be covered. See, these are abruption, postpartum hemorrhage, inversion, dystocia, and then there is maternal collapse that can be due to any of them. Then, so let's start with as I'm going to cover only this uterine inversion in this class. So I'll move on to this. Just read this case carefully in 30 seconds written. So as we can see that when you arrive in the labor room, the midwife is there with the uterus inverted and placenta attached, right? So first thing it has already been written that it is uterine inversion. So now the questions are there for you guys. So can any of you tell me that what is the differentials you have in your mind for uterine inversion? Akanksha, any one differential if you can tell me?
Ma'am, polyp could be prolapse.
Okay. And another one, Dr. Arif?
Prolapse.
Yeah, uterovaginal prolapse, it can be the differential. Dr. Arif, the patient is collapsed. What DDs and something is coming out of the vagina. What DDs you can speak here? See, two things Akanksha has told me. That is for the mass, DDs of mass coming out. Now, what can be the DDs of collapse? Shaista, can you tell me two or three differentials for the collapsed patient?
Ma'am, in view of collapse, it could be because of amniotic fluid embolism.
Right.
It could be because of some. It could be because of drug toxicity, collapse, and bleeding at the time of
The
delivery.
patient has mass coming out, and simultaneously he has collapsed. So this mass, if it is a fibroid, if it is a inversion, if it is a polyp, if it is a third stage, so related to that, what DDs you can think? Yes, amniotic fluid embolism you can think anytime, but just stick to that. And if it is a mass and it is an inversion, that can be neurogenic shock. Okay, if it is a fibroid, or it can be a PPH, so postpartum hemorrhage can be there. So you have to rule out that that can be the cause of collapse. Okay, so speak three or four differentials and give the reason why you are thinking that. Okay. Now, what will be your immediate management action on being faced with this case?
Ma'am, as it is an obstetrical emergency, so first of all, I will call for help and resuscitate the patient. And for that, I will make sure that airway breathing and circulation all are maintained. And cannula is already inserted. So for that, we will involve the consultant anesthetist and whatever help is available, like midwives, nurses, and blood bank as well. So after that, there is no need for removal of the placenta at the beginning. First of all, after resuscitation means first of all we will give the fluids and check the vitals and tone of the after abdominal and vaginal examination. First, it is confirmed. Then, first we will give the fluids if patient is hypovolemic, and order the blood for cross matching. We'll make sure that iron is already maintained. And first of all, we will manually replace the uterus rather than removal of the placenta. And if it is successful, then well, after that we will give oxytocin and further management. But there is, if it is not successful, then there are other methods like O-Salvel technique of replacement of the uterus, and hydrostatic pressure, and in which we instill the vagina with I think 1.5 liter of fluid and replace the uterus under gravity. If it is not successful, then there are surgical maneuvers like Hilton technique or Hilton technique or Hunton procedures um, by doing laparotomy. For that, we will definitely involve the consultant.
Okay. Yes. So now, so first thing you will do is pull on the buzzer. What will you do? Buzzer. Then you will be calling your team, stating the emergency, name of emergency. Emergency name you will be stating very clear. Okay. Then you are you are asking the team to come, because this is not possible to deal any emergency without the team. Okay, so these are the first three things which you are going to do. You are going there, you're pressing the emergency buzzer, clearly stating the emergency name, what kind of emergency has happened. You are going to involve multidisciplinary team, because it is a task or to be dealt by the expert, by the team, not by a single individual. So call the senior midwives available. Then I'll ask the labor ward coordinator to also join and come instantly wherever he or she is. Then I will tell them to involve more staff for for the things which may be required, like some porters for bringing on the bloods, and one person, and I will like to involve the anesthetist, senior anesthetist, because the patient is in shock. So, and the uterine inversion is there. So we need, so the cause of shock in uterine inversion is most probably the neurogenic one. So I will be requiring anesthetist to manage the shock part, and then one person for documentation, and then I'll be assigning the task to the team um, as per the roles. One person, I'll ask the senior person, either the midwife or the coordinator, to talk to the patient and also inform the partner that this complication has happened. Now immediately the patient, simultaneously we will start the resuscitation. We will see that the patient we will check for the, start with the ABC, and whatever fluids are required, or we'll check the airway, breathing and circulation. Two wide bore cannulas will be put, um, probably the 16 gauze, and IV fluid will be rushed. From the another cannula, we'll take out the samples. Okay, samples for the, for what? For what you take out the samples? For the full blood counts, for the coagulation profile, the clotting thing. I want to know the coagulation profile, liver function test, renal function test. For this, I'll be sending the samples, and also we'll take out, we will keep some blood for the cross matching, because she may require blood um, in case PPH happens, or she as she is in shock already. So if any coagulopathy happens, then she may need blood and blood products. So I'll keep the cross match aside. Way for the neurogenic shock to be resolved, the uterus should go inside. So now, earliest it will be done, better it will be. So in the labor room itself, we will do the manual reposition of the uterus. Okay. It can be done here. So this will be my initial management. Any doubt? No? So we'll go in the sequence. Don't speak this resuscitation in the end. Just say that simultaneously, I'll be starting the resuscitation. So the people knows that you are resuscitating the patient along with all this, whatever is going on. Okay, I'll check for the airway, breathing, and circulation. White board cannulas will be inserted, one for IV fluids, another one for taken out of the samples, and also blood and blood products cross-match will be required. So which samples you want to send? I want to send full blood count, coagulation profile, full liver function test, and renal function test. Why you want RFT, LFT? Patient is in shock. So I want to see the status of the other organs. Okay. So this will be your answer. And yes, not the least thing that you want to, in your immediate actions only, this shock treatment comes. So we know that, shock treatment require manual reposition. Okay. Manual reposition. So we will start here in the labor room itself. We'll not waste time. And why we want immediate replacement? Because as the time will pass, the edema can be there, the contraction ring can form, so the reposition may become very difficult. So earlier, the better. Okay. Now, what will be your subsequent management to this patient? Now, in subsequent management, whatever you have told Shaista in the first question, like till laparotomy, that part will come here as this for shock we are doing resuscitation, and manual reposition is a part of treatment of shock. So we have to do it as early as possible. So that will also come in the immediate management. Okay, done.
Yes, ma'am.
So okay, what will be your subsequent management of this patient?
Yes, ma'am.
Anybody want to add something?
Yes, ma'am. Once we replace, then we will start the oxytocin and then remove the placenta. And post management plan is also very important, in which we have to give the patient should be shifted to high dependency unit and for vigilant monitoring, antibiotics particularly, because there would be many replacement IV fluids. And then the part of clinical governance, this is also very important, in which documentation, debriefing, incident report, and duty of candor we have to take a like.
Okay. So now here again, I'm telling you one thing that you can see subsequent management. So here you will speak again whatever you have spoken in first question, extra things, right? O'Sullivan's, you will speak about laparotomy. Okay, these things you will speak, all the safety points you'll speak again. Then take a pause. Take a pause of 10 seconds. He will ask you. And if you will not stop, he will not ask you the third question then. Okay. Then again, you will not be having that much of time that you will be replying the third question all over again. Okay. If you will speak all the things in second question till post-operative things, then you may miss the third question's answer due to the time lag, and third question carries its own marks that will not be given to you if you will give the answer of third question in second. Understood? So you have to keep your body language in a way that you have to give the pause after every question. And then if you feel that examiner is not asking, then that means that subsequent management also include the post-op part. Here, if you
Right.
can see, I have third and fourth question also, manual reposition in this patient. We do the manual reposition. The part which comes out last should be replaced first. So under all aseptic precautions, I'll wear the long gloves, put my hand till, it may involve my two-third of my forearm as well. So we'll be following the umbilical cord, and the part which has come out last, we'll hold that part with the palm and push it inside the tummy and till above the umbilicus. And I'll keep that part over and I'll support the uterine fundus over there with my hand, with the same palm, for a few minutes. It may require for few minutes till the time uterus get contracted. Okay, and once I can feel that the uterus is enough contracted, we can start the oxytocin, and after that I can remove my hand. Placenta should not be removed until good contractions are there. Removal of placenta can be done when uterus feels contracted with fundal guarding. Here, the safety is guarding the fundus again because it can be due to, the most common cause or most common risk factor is, removing the placenta, unguarding the fundus. And consider if this method fails, we can consider giving tocolysis. But as such, the chances of postpartum hemorrhage are more in uterine inversion. We really have to wait. If we feel that contraction ring is there and the tone is bothering the inward placement of the uterus, then we may give tocolysis in the form of subcutaneous terbutaline or glycerol trinitrate. Maxils can also be used, but for the success of the treatment. Um, but if this also fails, then there is another hydrostatic method. Okay. In hydrostatic method, it can be done in labor room if patient is having been given epidural anesthesia. Okay. Because epidural analgesia, I'm sorry. So epidural is the prerequisite of doing it in the labor room. And consultant should be aware that you are doing this procedure. Okay. My consultant should be aware that this thing is going on and I'm doing the hydrostatic method in the labor room. And safety here is that I need to rule out that uterus is not ruptured. Okay, uterine rupture is to be excluded first before performing this. Now, patient is put in lithotomy position. If it has to be done in OT, general anesthesia will be given, right? 2 liters of the fluid will be passed um, in vagina. Okay. Um, a vacuum can also be used for making the seal around the vagina, or with the palms, it can be the negative pressure can be created. But better will be vacuum. And this is generally, this is called O'Sullivan method, and mostly the uterine inversion is uh, successfully reposited back inside the abdomen. So that can be used. But though sometimes, like in 3 to 4% of the patients, they require laparotomy if this process remain unsuccessful. There are two types of procedures. One is what did you say? That Huntington's. It is Huntington's procedure. Okay. Um, Huntington's procedure. And nowadays we do its modified form, modified Huntington's, because previously in this laparotomy is being done, and then this Alice forceps, they are applied on the sides of the crater, pulling the edges where round ligament and fallopian tube get attached to the fundus. From there, a pull is being maintained and the forceps are being advanced so that the uterus comes back. Okay. Um, fundus with the pressure, fundus comes out of that crater. Okay. So this is, and in modified Huntington's, we don't use Alice forceps, we use vacuum to make the seal and to create the pressure. Okay. And what it does, just give me a second. I think so. In modified Huntington's, we know that we use the vacuums nowadays. Apart from that, this procedure can also be done laparoscopically. Some cases have been reported where laparoscopic repair has been done. Another procedure is Halton's, the manual reposition. If it fails, we will give the tocolysis. If it still doesn't help, we'll start with the hydrostatic method. That's O'Sullivan's method. And in that, the safety is that we need to rule out the uterine rupture. And apart from that, the consultant should be knowing that we are doing this procedure, and that this thing, if it is being done in the ELA, the proper analgesia in the form of epidural. It should be there. If it is not there, we need to shift the patient to the operation theater. Under general anesthesia, we perform the procedure, and in this we make a seal around the vagina with the hand or with the mops, and we insert a tubing, and 2 liters of the fluid with pressure is being pushed inside the vagina and filled inside the vagina, and it helps in putting the uterus back into the abdomen. Okay, so mostly this method is helping. If it does not help, then in 3 to 4% of the patient, laparotomy can also be required. So the procedures are nowadays we use this modified Hutting-Dons procedure. In this, the Alice forceps laparotomy is being done, and Alice forceps are being applied on the edges of the crater where round ligament and the fallopian tubes can be seen at the edges or dipping down inside, depending upon the degree of the inversion. So we put the forceps and we keep on, pulling it upwards so that the uterine fundus is also being pulled upwards, and we keep on advancing the forceps so that finally the fundus comes up inside the abdomen and the inversion disappears. So this is the Hutting-Dons procedure. Not Dons, it is Dons. Nowadays, modification is being used that despite of using the Alice forceps, we use the vacuum, um, vacuum cup on the crater to generate the negative pressure. Okay, and then there is Halton's. How does this help? In Halton's, we give a incision. We give a incision on the, like suppose this is the cervical ring, contraction ring has been formed. Now the uterus is dipping down through the cervical ring. So now if this is a contraction ring, it will not allow the uterus to come up. So what we do, we give the vertical incision on the posterior aspect of the cervix and we stitch it after the reposition. Rest other steps are same as the Hutting-Dons procedure. In this, for Alice forceps, once the incision has been given, Alice forceps will be applied here, and it will be pulled upwards. Upward pressure will be given on the Alice forceps, and then the part which has come upwards or out of the crater, the Alice will be advanced to the next part, which is still inside the crater. And again, the pressure will be given upwards, and that part will come, and slowly and steadily, the uterine fundus will come out. And later on, this posterior incision will be repaired. Okay. So, understood? Am I clear so far? Any queries? We can discuss it now and kill it now. Shaista?
Yes, ma'am, clear.
Clear? Forceps on the edges of the crater where fallopian tubes and rounds can also be seen inserting, and we should advance. And in Halton's, you are giving a posterior incision on the contraction ring, longitudinal incision, and rest other steps are same as of modified Huntington's. No, as a last resort, we may need to perform the hysterectomy if these measures fails and patient develops PPH or patient is in collapsed state, still in the collapsed state. Okay, and patient is critical. We can't just keep on, waiting or doing the fancy procedures. Sometimes in these laparotomy thing, you can say if patient is stable, then laparoscopically also these procedures have been tried. But we need to keep in mind the stability of the patient and the problems associated with pneumoperitoneum in a patient with shock. Okay. So this is the answer to your second question till here. All right. Now you see that what is the next question? Here, what other step? Now you will stop after subsequent management, after laparotomy, after hysterectomy, you stop. And in this patient, as a post-operative part is also very important, after reposition of the uterus, the same things which you said, I'll make sure the documentation of the series of events have been done. This patient will be shifted to the high density unit. Meos charting will be started hourly uh, to know the pulse, blood pressure, respiratory rate, saturation, oxygen saturation, and intake output charting. Um, Hourly, this will be done so that any deterioration of the patient's condition will be captured at the earliest possible time, and we can manage it. In the medicines, we'll give the patient antibiotic cover. Okay. In all the emergency, in post-op period, first you decide where will you give the care. It will be ICU, HDU, or the ward or the room. Okay. And then, like in depression patients, psychosis patients, you will keep the patient isolated, different from the ward. Similarly, here you will keep the patient in high density unit and where she will be observed regularly with a team of doctors and medication and liaison with the anesthetic team. We will give her the antibiotic cover, also the IV fluids, and oxytocin will be given to her because she is at risk of developing PPH. 40 units and 500 ml of normal saline in 4 hours. It will be given. Yeah, and we'll check for we'll send her full blood counts and coagulation profile again. And also, if any investigations to be sent by the anesthetist, we'll send that. And with the reports, we'll check for any anemia or any coagulopathy. If it has sets up, then blood transfusion or fresh frozen plasma, this can be given, right? And analgesia, according to the patient's pain score, it will be given to the patient. And if her blood group is negative, then we will give NTD. Starts to wait or get the NST करवा दो NST करवा के लिखिए पेन है हाँ कहते हैं okay so is there were we I'm sorry okay yeah so analgesia blood group is negative NTD will give see these are the patient safety points which we mostly miss in any emergency like in post-op period you should invariably be talking about the NTD, invariably be talking about the venous thromboembolism assessment. This VTE, the NTD, it will come. Analgesics, antibiotics, analgesia, fluid, and in all the emergency, fluids, and speak in liaison with anesthetist, we will decide about the fluids and as patient will be comfortable, we'll do the postnatal debriefing to the patient and to the partner. Okay, it as it know that this can reoccur. So you need to explain this to the patient and advise her the importance of having hospital delivery. Okay, and this can happen again. She may have the trauma of the events. So counselor can also you can put in picture. Okay, in all obstetric emergencies. In fact, in all gynae as well. So you can bring up the counselor because these events they sometimes put the trauma to the mental health or it can come up, it can develop into post traumatic stress disorder. So and fear for the future pregnancy and delivery be brought in and can be of help here. And then coming the can be some short-term complication and counseling about that can also be done during debriefing. Short-term means there will be long hospital stay. Patient can has to stay for long, and then there can be if PPH has happened, there can be anemia, and then in long term there can be this mental distress. Okay, so now coming on to the risk management issues. In risk management issues, now we know that there is some clinical governance issues are there to be addressed, the risk management issues. We need to do the incident reporting. We can do the audit as well to see how well the guidelines are being followed in the department, arranging for the teaching sessions and training sessions. Simulated teaching practices can be done. Lectures can be organized about the uterine inversion. Skill and drill trainings, they are very important. So in risk management issues, you can talk about incident reporting, you can talk about the root cause analysis, then we will be doing the audits to see how, then the teaching sessions we can organize the skill and drill trainings, okay, skill and drill training to reduce the morbidity and to handle the emergencies like this, as this is the way UK. So this can be done. And are the protocols for active management of third stage of labor being followed in the institute, and how well they are being followed? Because the active management of third stage of labor, it has reduced the incidence of uterine inversion by fourfold. Okay, so this is very important to know whether the active management of third stage of labor has been done or not. All right. So these are the risk management issues which I would like to bring in notice. Now, is there any questions from your side, or otherwise I'll just brief? Any questions you have?